Repaglinide, acarbose, voglibose, all of these take care of postprandial hyperglycemia, and we have combinations of repaglinide with voglibose in our country, which I use in quite a lot of patients with steroid-induced hyperglycemia with good efficacy. GLP-1 receptor agonists, DPP-4 inhibitors take care of postprandial glucose. Particularly helpful are the GLP-1 receptor agonists because they reduce body weight and blood pressure as well, which might increase when you are using steroids. Now, metformin and pioglitazone are good drugs, but they are very slow acting. And with pioglitazone, there's the concern of weight gain, fluid retention, fractures, which could be additive to the effect of steroids on the same adverse effect. Interestingly, with SGLT2 inhibitors, with dapagliflozin, there have been studies which have shown that it does not reduce blood glucose when given with a glucocorticoid. I don't have an explanation for the same, but in steroid-induced diabetes, SGLT2 inhibitors are not effective, and they might increase the risk of genital tract infection and urinary tract infection, particularly because of the immunosuppressive effect of steroid increasing the risk of infection as well. Now, of course, insulin is the star. It's the hero or the heroine, whichever way you put it, in managing steroid-induced diabetes because it's quick acting, it's flexible, it's efficacious. So in those who are on pre-existing insulin, someone who is known to have diabetes is already on insulin, the rule of thumb when you initiate a steroid is to increase the dose of insulin by about 20%. If the patient was on basal insulin or NPH insulin, if it was being given in the evening, you shift it to the morning. If the patient was on premixed insulin twice daily, you increase the morning dose by about 20%. In those not on insulin, in whom you are thinking of initiating insulin, in someone who is on prednisolone or methylprednisolone, you can give a NPH insulin with the morning dose of methylprednisolone or prednisolone because both of them will act together over the 12 to 16 hours. And how do you initiate NPH? A rule of thumb is you take the dose of prednisolone, divide it by 100, that's the initiating dose. Like if you begin with 10 milligrams of prednisolone, begin 0.1 unit per kg per body weight of NPH. If you begin with 30 milligrams of prednisolone, begin with 0.3 units per kg per body weight of NPH insulin. However, if the age is more than 70 years or the eGFR to begin with is less than 30, that is renal dysfunction, you begin with half of this initial dose of NPH. Similarly, in the outpatient setting, in those on long-term glucocorticoids, suppose you begin with a short-acting gliclazide or with a repaglinide and an acarbose combination and you're not getting results, you can also consider adding an NPH insulin along with the morning dose of prednisolone in those on long-standing steroid therapy. So if you are on a dexamethasone, a long-acting basal insulin is a better will better mirror the glucose control over 24 hours. And if you are only on hydrocortisone, a simple regular insulin or an insulin analog, rapid-acting insulin analog might be good enough for glucose control. Now, having said that NPH insulin mirrors the glucose increasing capacity of prednisolone and methylprednisolone, there are studies which have used glargine instead of NPH insulin with prednisolone or methylprednisolone over long term and have shown similar efficacy without nocturnal hypoglycemia. So in my practice, in some I use NPH insulin, in some I also use glargine along with prednisolone or methylprednisolone as well. And again, when a single shot of insulin is not working, particularly in inpatients, you can always shift to the good old basal bolus regime. Look at the pre-meal and post-meal glucose, and there are certain rules of thumbs. Again, you can follow your own practice or you can follow this as well to increase the level of the basal bolus regime. Now, in obstetric practice, particularly in preterm delivery, antenatal steroids are used, and a lot of these patients might have pre-existing diabetes. So usually 2 doses of dexamethasone or betamethasone are used 24 hours apart. And from the first dose till about 72 hours, or at least till 24 hours after the second dose, the blood glucose levels might be high. And they might be quite high if you look at, because in diabetes in pregnancy, we follow more strict blood glucose targets. In about 90%, it could be more than 126. In about 50%, it could be more than 180, which is very, very high if you look at the targets for hyperglycemia in diabetes. So here the rule of thumb is not to increase the dose by only 20%, rather the rule of thumb is to increase the dose of insulin by as much as 50%. The reason being, one, higher doses of glucocorticoids are being used here. Two, in hyperglycemia in pregnancy, our targets are very stringent. And of course, the moment you give the first dose of glucocorticoid, over the next 24 hours, you need to measure glucose at least 4 to 5 times, particularly in the afternoon to the evening time. And the moment 2 consecutive glucose levels are higher than your pregnancy targets, as per recommendation, the patient needs to be put on variable rate insulin infusion, that is on IV insulin using an insulin pump. And if the patient was already on a basal insulin, you can continue the basal insulin as well as keep the patient on the insulin pump. So we have a very short time frame here. Increase it by 50% the insulin, measure if 2 consecutive glucose levels are high. Ideally, the patient needs to be put on an insulin pump. Now again, can't we design better glucocorticoids which have immunomodulatory activity but do not increase blood glucose? There are trials going on and the results are still not very good. And of course, there are also trials going on which are targeting the intracytoplasmic pathways which are responsible for the immunomodulatory effect of glucocorticoids involving, for example, the heat shock protein or histone deacetylase, or pathways involved in generating ceramides or serotonin, which play a role in increasing blood glucose. From the steroids play a role in increasing blood glucose through these pathways. So small molecule inhibitor antagonists are being designed, they are being tested in laboratory animals so that the immunomodulatory effect of glucocorticoids are preserved, but the gluconeogenic effect, the lipogenic effect of glucocorticoids can be countered, but again, it's very early days to speak of this. So you began something, you might also stop glucocorticoids, at least in some individuals. And it's important to keep in mind that the doses of oral anti-diabetic agents or insulin need to be tapered down as well, because unless you do that, the patient is going to land up in hypoglycemia. And again, there's a rule of thumb which says that if you reduce the dose of prednisolone by 5, you can reduce the dose of insulin by about 20%, you can reduce the dose of gliclazide by about 40 milligram, and then you need to follow up and monitor and change your dose as necessary. It's important to keep in mind that long-term monitoring is necessary. Even after stopping glucocorticoids, as many as 1/3 of patients might develop permanent diabetes. So if someone develops glucocorticoid-induced hyperglycemia, ideally lifelong monitoring is necessary. Some of these individuals might develop microvascular complication even later on. There's no consensus as to how long they need to be screened for microvascular complications, but they need to be screened lifelong for diabetes at least once annually, once an individual has developed glucocorticoid-induced hyperglycemia. Now this is a slide which sums up everything. I feel it's very difficult to read from there. What it says that when you are initiating glucocorticoid, you screen for pre-existing diabetes. If there is pre-existing diabetes, you monitor blood glucose at least 4 times daily. In the absence of pre-existing diabetes, you monitor blood glucose at least once daily, increasing to 4 times daily if 2 consecutive values are more than 200 milligrams per deciliter. Once you feel that there is high blood glucose, more than 180 or more than 200 milligrams per deciliter, initiate therapy. In those with not known to have pre-existing diabetes, blood glucose not very high, you can consider beginning with oral drugs like repaglinide, like voglibose, acarbose, or immediate release gliclazide. You can consider using a DPP-4 inhibitor, you can consider using GLP-1 receptor agonists as well. When you have to initiate insulin, you can use an NPH or glargine. Again, 10 milligrams prednisolone, 0.1 units per kg per day is the initiating dose. As and when necessary, you need to add a short-acting insulin as well. And the important thing is to taper down the dose of the anti-diabetic agent when you are tapering down the dose of glucocorticoids as well. Even if the blood glucose comes down to normal, after cessation of glucocorticoids, lifetime monitoring for diabetes at least once annually is necessary. So I end with this image. Can anyone tell me what this image is depicting, or from where is it taken?
Olympics.
Olympics, yes. So
Yes.
what's being shown here? So yes, this is the artistic swimming or synchronized swimming or rhythmic swimming. The Chinese team got the gold medal here, and they swept the gold medal in the diving synchronization competition as well. So I've given this just to put the message across that when you are talking of steroid-induced diabetes, it's synchronization which is the key. There are different glucocorticoids with different modes of increasing blood glucose. You have to chase the blood glucose depending on the glucocorticoid you're using. You have to synchronize your anti-hyperglycemic therapy with the hyperglycemic potential of that glucocorticoid. And similarly, when you're tapering down the glucocorticoid, you need to synchronize your tapering down of the anti-diabetic therapy as well. So thank you.
Thank you, Dr. Goswami. Well said. And from your deliberation, it is very clear that monitoring is the key in management of this subset of patients. Now, one or two questions that I would like to pose. One is, you never mentioned about metformin. Number
Yes,
two, your experience on repaglinide in these patients.
So metformin and pioglitazone I did mention as insulin sensitizers. The problem with both is that they have a slow onset of action. So when you're talking of an inpatient or you're using the glucocorticoid for 2 to 3 weeks, their action might not start in that short period. In long term, if someone is on glucocorticoids for years and you know that this individual is going to stay on glucocorticoids, both metformin and pioglitazone as insulin sensitizers have an excellent role to play, because insulin resistance at the level of the liver and the muscle plays a big role in steroid-induced hyperglycemia. Having said that, the problem with pioglitazone, as I said, is that steroids cause fluid retention, heart failure, osteoporosis, weight gain. Pioglitazone also causes the same. So the adverse effects could add up over time. And the second question was regarding?
Repaglinide, your experience.
Yes. So repaglinide with acarbose or with voglibose fixed dose combination, which are available in our country, I do use them in the outpatient setting, and I've got good results, at least in a certain number of individuals. Now, when they don't work alone, I have to add an NPH insulin or a morning dose of glargine along with them for blood glucose control. But in some, even without initiating insulin, they do work.
Thank you. Yeah.
Hyperglycemic response, if you give a single dose of steroid versus multiple dose, which is better?
So again, the regimen determines, like a daily regimen of glucocorticoid will increase blood glucose more compared to an intermittent or a pulse regimen. So similarly, if you are using hydrocortisone twice daily or thrice daily, it's almost like using a dexamethasone. So the glucose level will persistently remain high over 24 hours. Similarly, if you are using a prednisolone twice daily, it's almost like using a dexamethasone. So their longer acting insulins will be even better compared to NPH insulin.
So single dose is better when compared to the
Single dose, intermittent dose, they're always better in terms of the glucose increasing thing.
Okay. I think with this we'll wind up the first talk. Thank you very much. And
thank you, sir, for an enlightening talk. We now request Chairperson Dr. Sidney D'Souza to hand over a token of gratitude to our speaker.
We now call upon our next speaker, Dr. Samir Agarwal, to talk on screening for diabetes complications.
Welcome to the next session after an interesting session on steroid-induced diabetes. Screening for diabetic complications has been going on for several years. Microvascular and macrovascular complications. So, sir is here to tell us the latest guidelines on the screening protocol being followed right now. Dr. Samir Agarwal is currently a consultant endocrinologist and is affiliated to Dr. Samir Agarwal's Endocrine Center, Rohtak, Haryana. He has finished his DM Endocrinology from AIIMS, Delhi. He is a recipient of A.V. Gandhi Award for the best clinical acumen in endocrinology. He has been the editor of Insulin Manual. He has been the editor of a manual on pregnancy and thyroid disease. He is also the editor of clinical manual on SGLT2 inhibitors, and he has been a reviewer for Indian Journal of Endocrinology and Metabolism. He has several research interests including metabolic bone disease and PCOS. Sir, I leave the stage
Thank
to
you,
you.
sir. Thank you for nice words. Thanks, Dr. Ganesh and his team for inviting us here. So my job is to talk about screening for diabetes complications. Most of my presentation has been adapted from ADA 2024 standards of care. And I think we all have been dealing with type 2 diabetes, and majority of our endocrine OPDs also have diabetes. But we want to screen and prevent diabetes complications. So we will be going through this data. I think the traditional complications we talk about, yes, microvascular and macrovascular complications, but I think we are seeing more and more emerging complications like liver disease, functional disability, cognition issues, some neuropsychological issues also in diabetic patients. So I will be touching on those aspects also. And we must know that these are the level of evidence, A, B, C, and E. A is, of course, from well-conducted RCTs. So one of the commonest, I think, thing is diabetic retinopathy. And we know that once the fasting plasma glucose is reaching more than equal to 126, the risk for diabetic retinopathy increases. In fact, this cutoff was developed looking into the incidence of retinopathy only. And we know this retinopathy can progress, and we can have especially uncontrolled diabetic patients suffering from retinopathy. And you can have maculopathy or macular edema even in well-controlled diabetic patients. And many patients do not develop typical symptoms like floaters or blurring of vision till the retinopathy is advancing into the advanced stage. So you can have these blurred vision, flashes of light, and maybe sudden visual loss also. So screening methods are very simple. Dilated fundus examination or retinal photography. So if you have the facility in your clinic, you can do yourself. Of course, the fundus examination, if done by ophthalmologist or the persons who are trained into it, the chances of picking up increases. But you can also go for retinal photography also. The guidelines recommend that at the time of type 2 diagnosis, type 2 diabetes diagnosis, we must do a dilated fundus examination and a comprehensive examination level B evidence. And the frequency goes depending upon the prevalence of retinopathy. So if it's already there, then we need maybe more frequent examinations. For type 1 diabetes, adults with type 1 diabetes should have an initial dilated and comprehensive eye examination by an ophthalmologist within 5 years after the onset of diabetes, since these complications take a little bit more time in type 1 diabetic patients to develop. So do we need to have this remote screening, or what about artificial intelligence? Now you have these fundus cameras, and maybe the report for fundus is done by the artificial intelligence algorithms. So the latest consensus is that the programs that use retinal photography with remote modeling, or the US of FDA approved artificial intelligence algorithms, level B evidence is there. Yes, we can incorporate, but we have to be careful where the artificial intelligence algorithms will not be into picture, and there are some limitations, like they will not identify non-diabetic retinal diseases. Already, if the patient is known for diabetic retinopathy, he has proliferative or non-proliferative diabetic retinopathy, we should avoid going for these algorithms. In pregnant women, they can have sudden shifts in the fundus examinations, or any vision symptoms like blurred vision or floaters which are currently there. I think we should be relying more on a dilated fundus examination. Another complication is nephropathy. So I think we know that the patients of type 2 diabetes are at risk for developing nephropathy. There is glomerular hyperfiltration, progressive albuminuria, declining EGFR, and ultimately end-stage renal disease. So if you are able to find out whether a particular index patient of diabetes has presence of albuminuria or not, or decrease in the GFR, then I think we can start the treatment to prevent the progression or in fact even the onset of nephropathy. So screening at least annually, urinary and albumin creatinine ratio and estimated GFR using the CKD EPI 2021 equation should be assessed in all patients with type 2 diabetes at the onset, and in type 1 diabetes if they have a duration of diabetes more than equal to 5 years. If the patient has already established chronic kidney disease, then we should be monitoring more frequently eGFR and urinary albumin creatinine ratio. Important thing is that we must look for both eGFR as well as spot urinary albumin creatinine ratio, since many patients of diabetes can have even normoalbuminuric kidney disease. And if you find that the patient is developing rapidly progressive derangement in the GFR, or there is some active urinary sediment hematuria, then I think we must look for some non-diabetic causes also of nephropathy in an index patient. Another complication can be neuropathy. So the things are clear that at time of diagnosis of type 2 diabetes, we must screen for presence of neuropathy, and 5 years after the diagnosis of type 1 diabetes and maybe annually thereafter. So symptoms, we must look for symptoms of neuropathy, and then depending upon we can do the clinical examination. So symptoms like you can have paresthesias, numbness, loss of protective sensation, and screening clinical test class B evidence is that pinprick and temperature sensation, and the tuning fork 128 Hz should be used for assessment of large fiber function, and 10 gram monofilament for the protective sensation. So should we do electrodiagnostic studies in all type 2 diabetic patients if they are showing symptoms and signs of neuropathy? I do not think we should be going for electrodiagnostic studies like nerve conduction velocities in all patients, which we sometimes see patients coming up with those reports. So ADA guidelines and most of the professional organizations are very clear that if the patient of type 2 diabetes has typical symptoms and signs of glove and stocking presence of neuropathy, clinical examination like loss of ankle reflex. Ankle reflex loss can occur quite early on in diabetic neuropathy, whereas loss of generalized reflexes occur later on. So that's, I think, is more important. But sometimes atypical presenting features like asymmetry of symptoms or signs of neuropathy, initial presentation with motor weakness more than the sensory, and rapidly progressive neuropathy course, we go for a electrodiagnostic studies and a neurological consultation in that case. And some features sometimes of diabetic neuropathy are overlapping, or we are confused whether it is peripheral arterial disease or a vascular disease. So site of pain, presence of rest or not, effect of walking can differentiate whether it is a pain in the limbs which is favoring neuropathy or a vascular disease. Another area which I think is missed sometimes in our busy practices is presence of autonomic neuropathy. So we should be alert that if any patient is complaining of some resting tachycardia, postural dizziness, then any erectile dysfunction, symptoms suggestive of gastroparesis like nausea, vomiting, early postprandial fullness, these are dry skin. I think these are all symptoms suggestive of autonomic neuropathy. So we should be alert that if the patient has any of these signs and symptoms, hypoglycemic unawareness, neurogenic bladder, and pseudomotor dysfunction, it can suggest you that autonomic neuropathy may be present. So you need to check for the postural drop in the blood pressure and check for the resting tachycardia. So the guidelines say that assess for presence of autonomic neuropathy in type 2 diabetes, and 5 years after type 1 diabetes and annually thereafter. particularly if there is evidence of microvascular complications, particularly nephropathy and peripheral neuropathy. Diabetic foot, the examination has to be done if the patient has history suggestive of peripheral vascular disease, any CAD, neuropathy, presence of sensory loss or prior amputation or ulceration, inspection of the skin, assessment of musculoskeletal deformities, foot deformities, and neurological assessment and vascular assessment has to be done. The lower extremity pulses, particularly dorsalis pedis and posterior tibial, can be checked easily, and venous filling time. And if the patient has history suggestive of leg fatigue, claudication, rest pain, relieved with dependency or decreased or absent peripheral pulses, he should be referred for ankle brachial index measurements. Of course, you need to measure systolic blood pressure in the brachial artery, in the dorsalis pedis, and in the posterior tibial artery. And you divide the higher readings in the lower limbs divided by the systolic blood pressure in the brachial artery. So if the index is like less than 0.9, it is usually suggestive that there is peripheral vascular disease. So macrovascular complications in type 2 diabetes, we know that coronary artery disease, stroke, peripheral arterial disease, and heart failure incidence is increased. And it can progress, especially in uncontrolled type 2 diabetes. So you can be alert of presence of macrovascular disease like CAD if the patient has symptoms of chest pain, dyspnea, easy fatigability. So that can be some subtle symptoms in type 2 diabetes. So overweight, hypertensive patients, smokers, presence of albuminuria, they are significant risk factors for presence of CAD. So resting ECG can be performed in patients who are elderly, patients age more than 40 years or duration of diabetes is more than 15 years and end organ damage is there. But asymptomatic patients, routine screening for CAD is not recommended as it doesn't improve any significant outcomes. Investigations for CAD should be done in presence of cardiac symptoms, whether chest pain, chest discomfort, dyspnea, or signs and symptoms suggestive of vascular disease like carotid bruit, transient ischemic attacks, stroke, and claudication, presence of peripheral arterial disease, or ECG showing Q waves. In these four categories, we can undertake the patient for presence of CAD. So these are various non-invasive tests which can be used for presence of coronary artery disease, TMT, exercise stress echocardiography, exercise nuclear scan studies like stress SPECT studies, dobutamine echocardiography, coronary angios, CT angio, and pharmacological stress SPECT. Each have their different sensitivity and specificity. Of course, they will all depend upon the institute where you are working and accessibility to these various non-invasive tests. So if the patient on stress test, exercise stress test, TMTs, has some unfavorable prognostic signs like poor exercise capacity, exercise-induced angina, abnormally low peak systolic blood pressure, late heart recovery, or fall in systolic blood pressure, these are poor prognostic signs indicating presence of CAD. On nuclear imaging, if there are some perfusion defects or dobutamine stress echocardiography showing some left ventricular dysfunction or valve motion abnormalities, again, they are a marker for CAD. Some risk predictors can be used, but you need to have access to these calculators in your busy OPD practices. Candidates for advanced invasive cardiac testing should include those type 2 diabetic patients or type 1 elderly patients who have cardiac symptoms and an abnormal resting ECG. In adults with diabetes more than equal to 40 years of age, symptoms of CAD, measurement of coronary artery calcium score is also reasonable for CV risk assessment. Of course, it will depend on the scores of CAC which the patient is having. More than equal to 100 is suggesting sometimes that maybe the patient is having CAD. It is not, CAC scores will not differentiate between the obstructive and the non-obstructive lesions, and the scores going beyond 400, they are significantly positive, suggestive of obstructive artery disease. Pharmacological stress echocardiography or nuclear imaging, if the patient is showing resting ECG abnormalities like LBB or STT abnormalities, unable to exercise, then we go for stress echocardiography, nuclear imaging, and maybe then invasive diagnostic test like angiography. Silent CAD can be present in many type 2 diabetic patients since they do not have typical symptoms sometimes of chest pain. Presence of autonomic neuropathy again predisposes for silent CAD. So patients who are having peripheral arterial disease or high coronary artery calcium scores and type 2 diabetic patients with proteinuria, these group of patients should be suspected for CAD, which can be present in these patients. Heart failure, again, both systolic as well as diastolic dysfunction can be present in type 2 diabetic patients. So we should be alert for presence of heart failure if they have symptoms of dyspnea, pedal edema, fatigue, tiredness, or ankle swelling. Factors associated with heart failure in adult type 2 diabetic patients will depend upon the duration of diabetes, microalbuminuria, greater BMI, derangement in the renal function tests, peripheral arterial disease. These are factors associated with heart failure in type 2 diabetic patients. So careful medical history is important, but ADS suggests that adults with type 2 diabetes measuring a natriuretic peptide that can be helpful. If it is raised, then going for echocardiography to diagnose early heart failure. Peripheral arterial disease, ideally we should be looking for peripheral pulses in type 2 diabetic patients. Class B evidence is there in all type 2 diabetic patients. Symptoms of peripheral arterial disease like claudication, rest pain, non-healing wounds, we should be doing this. Asymptomatic individuals with diabetes and age more than equal to 50 years, microvascular disease in any location, foot complications, we should be going for screening for peripheral arterial disease with ABI index in these patients. Diabetic duration more than equal to 10 years, screening for PAD should be considered. So these were all classical complications like microvascular and macrovascular, but we are encountering more and more non-classical complications since we are having increased in longevity also of type 2 diabetic patients. Many are overweight or obese. So cognitive impairment and psychological dysfunctions, depression, and NAFLD. I think these are emerging complications. So we should be screening type 2 diabetic patients more than equal to 65 years of age for presence of cognitive impairment, since it can affect their hypoglycemic management, the insulin use in these patients. And depression also should be considered in patients of type 2 diabetes. NAFLD and non-alcoholic steatohepatitis or MASLD, these are emerging complications or in patients of type 2 diabetes. It can cause fibrosis and cirrhosis later on. In fact, NASH seems to be one of the leading cause for liver transplantation. So patients with type 2 diabetes and even of pre-diabetes should be screened for liver fibrosis, since if we are using a SGALT or SGPT and SGOT criteria more than 40, then maybe we miss at many patients with significant NASH. So FIB4 index, which is easily available online, even if the patients have normal liver enzymes, they should be taken into account in type 2 diabetic patients. In fact, American College of Gastroenterology recommends ALT cutoff of 33 and 25 in males and females. So that seems to be lower as we usually look into our reports of type 2 diabetic patients. Adults with type 2 diabetes or pre-diabetes with a indeterminate or high FIB4 index. So if it is less than 1.3 FIB4 index, usually normal, more than 1.3 we should be alert, and if it is going beyond 2.6, then FIB4 index is significantly risk factor for advanced fibrosis in type 2 diabetic patients. So if it is indeterminate or high, we should be doing a risk stratification by doing a elastography or blood biomarker ELF, enhanced liver fibrosis marker. So patients of type 2 diabetes with elevated and transaminitis for more than 6 months and low Fib should be evaluated for other causes of liver problems. So Fib4 I think is definitely recommended now to be evaluated in type 2 diabetic patients. So if it is high, we go for elastography. If it is or ELF blood test, if they are high, then maybe the patient needs a liver biopsy and a hepatology consultation. So these are comorbidities which can occur in diabetic patients. So we screen for usually thyroid dysfunction annually in our type 1 diabetic patients, and for celiac disease also in type 1 diabetic patients, particularly if they have symptoms suggestive of malabsorption. Vitamin B12 can be considered, patients having anemia. Bone health is one of the ignored areas. So from endocrine point of view, we think that we should be screening older adults for bone health. Adults more than 65 years of age, we should be using DEXA, and especially if they are having a T-scores less than equal to -2. Since the quality of bone is usually deranged in type 2 diabetic patients, so the scores which we usually take for postmenopausal females of more than equal to -2.5, they are a little bit lower in diabetic patients. So diabetic duration more than 10 years, poor glycemic control, presence of retinopathy and nephropathy, these are risk factors for osteoporosis. So type 2 diabetes, 5 years after the diagnosis, reassessment periodically should be done. And for type 1 diabetes, after the age of 50, hip fracture risk increases. Carcinomas can be there as age-specific carcinoma surveillance has to be done. Same has to be followed in type 2 diabetic and patients also. Functional disability, if it is affecting one or more than that major life activity, then we should be looking for this also and should be performed. Hypogonadism can be another comorbidity which can be there in diabetic patients. So this is again one of the ignored areas. So patients who are males complaining of decreased sexual desire, erectile dysfunction, just do a morning serum testosterone from 8 to 10 a.m. in the fasting state. Dental disease, I think again one of the ignored areas, but you have periodontal disease, and there are various papers which have shown that progression of periodontal disease occurs in type 2 diabetic patients. We did one study also in Rohtak that poor glycemic control was associated with poor healing of apical periodontitis. Similarly, hearing impairment can be there, and OSAs can also be accompanying. So we need to be vigilant for these sleep disorders also, not only in type 2 diabetic, but also in type 1 diabetic patients. So we have these various classical complications where we should be alert with regards to screening of microvascular complications, macrovascular complications, and emerging complications like NASH, NAFLD, bone health, cognitive impairments. These all have to be screened in our diabetic patients. Thank you.
Thank you, sir, for that nice and clear presentation. You highlighted that certain investigations might not be required in all patients, like electrodiagnostic studies also. We'll take only 2 questions now because of the shortage of time.
Most of the diabetic patients who come with fatigue tiredness, we attribute to hypoglycemia, blah, blah, etc. How many in your practice you have come across testosterone insufficiency? What is the cutoff level where you start testosterone replacement?
I think I think any patient, we must ask for erectile dysfunction. So it can be because of poor glycemic control, but yes, few patients have low testosterone. So you need to have these symptoms of erectile dysfunction, decreased libido. So we should be immediately alert if the patient is complaining of these symptoms. And if the testosterone levels, usually normal levels at 8 to 10 a.m. in the morning are 400 to 800 nanogram per deciliter. So if the levels are falling like below 200 to 300 nanogram per deciliter, we usually put them on testosterone. So you can have low testosterone because of problems in the testes, which is called as primary hypogonadism. And sometimes you can have problems in the pituitary also, so that can be hypogonadotropic hypogonadism also. But most of the patients, if they are demonstrating severe testosterone deficiency, less than 150 nanogram per deciliter, they will have a significant improvement with testosterone replacement. So that should be the cutoffs we must do. It has to be done in the morning in the fasting state.
In some patients, if the patient has finished 15 years of life of diabetes, duration of diabetes, and he has not developed renal complications, it's unlikely they develop a complication thereafter. What is your say on that?
So yeah, so not all type 2 diabetes or type 1 diabetes, so there are some genetic inherents also which goes with these patients. So but we need to have an annual screening for all diabetic patients, type 1 of course more than 5 years. But yes, many patients, if they are well controlled and they are on right therapy, so they will not develop nephropathy for lifelong.
Thank you, sir, for the enlightening talk. We now request our chairperson, Dr. Prashant, to hand over token of gratitude to our speaker.